which is on the topic of health system strengthening. We're privileged to have Dr. Francesca Cialetti, Director of Health System Strengthening and Sustainability at the Elizabeth Glaser Pediatric AIDS Foundation.
Good afternoon, everybody. Thank you very much for the introduction. Today I'll be discussing some of the trends and approaches to advance country ownership, to sustain the HIV response, and strengthen the health system to support this effort. So, why this question? As we are supporting countries to provide chronic care to millions of adults and children, we are faced with critical question. We are at the juncture of the HIV response. And how do we sustain today the progress that has been made so far? This is definitely the first question. The second one, how do we make sure that those who are tested today and start ART are virally suppressed for life? And how do we assure high-quality services? This is another critical point. And finally, also, we are asking ourselves, how would we support countries to be innovative and forward-thinking to prepare the health system to achieve and sustain the 90-90-90 target? We know that, and we have heard this morning a lot about the 90-90-90 target, and we definitely know that to reach this target, we need high political will and engagement. We need innovation. We need resources. We need all of this. But beyond that, in sustaining and further advancing these goals, we need a strong health system, and we need a country-owned response. Country-owned HIV response. So we ask ourselves, we talk about country-owned HIV response, but what is really, what is it? What is country ownership? So although the definition of country ownership changes a little, depending on the source, it is defined as when a country leads, implements, and eventually finances the national response to health and development. Recently, this definition has been broadened up by including not only national government, but also civil society, faith-based organization, the private sector, the community, the citizen, with the understanding that the national government alone will not suffice to sustain a good quality HIV response. HIV response in countries, as we all know, needs a multi-stakeholder engagement. Globally, there is a momentum toward country ownership, and we have seen it happening in several countries. However, we have two major transitions that have happened recently. The first one being the PEPFAR Track 1 countries, and the second, the Avahan project from Gates Foundation to the government of India. And by transitioning these two programs, we have seen that millions of patients, of people on ART, and literally billions of dollars have moved from international partners to national partners directly. And to this end, these slides here shows how in the last more or less 8 years, 10 years, to show how funding from the US government has increased, going to national entity, including government and civil society, has increased toward the years. Strong health systems are a critical component of country ownership. They are not two separate entities. It's part of one concept. So if we have to move toward country-owned programs, we do have to focus on health system. We do have to focus on national leadership. We do have to focus with clear planning, with commitment to equity. We do have to focus on sustained financial resources, with shared responsibility between the different stakeholders. We have to focus on a strong and well-resourced health workforce. We have seen today as all these issues are impeding the scale-up of HIV services, are part of those impeding the further scale-up of HIV services. We have to focus on high-quality data to inform and drive decision-making, as well as integrate a continuum of care and innovative and responsive technology and innovation. So going along this story, let's say, how do weaknesses in the health system affect the scale-up of HIV services, of any health services? We have done an analysis of the latest, in the last 10 years, reviewing the different reports, global reports that have been published, and from 2003 to 2014. And here you can see just the last 4, but I can assure you that results do not differ that much. We always come across similar challenges. And while we have issues like, of course, stigma and discrimination, human rights violation, criminalization as standing as very important, on the other hand, we also have weak health system in total, in their totality, or in some of their components, emerging as a constant challenges to scale up HIV services. The last one is a discussion paper, the 1919 discussion paper, that once again highlights how health system weaknesses are lagging the response behind. So health system is important, but what is health system? It's quite a difficult concept to many. It's a theoretical concept to others. So depending to whom you ask the question, you get a different answer. So starting with Churchill actually here, he was saying that it is a riddle wrapped in a mystery inside an enigma. We have asked the question to a very eminent health system expert who said it's a black hole, it's a black box, shopping list. However, if we go to the WHO definition of health system, we see here that health system consists of all organizations, people, and action whose primary intent is to promote, restore, or maintain health. And while the broader and long-term goal of health system are indeed a long-term effort, if we look at the intermediate goals, we see that this speaks to greater access and coverage of services, as well as quality and safety. And it's exactly on these intermediate goals that probably we should focus for the time being to further expand access to HIV services and to sustain them. So now the next question that maybe we want to ask ourselves is, how do we take this broad theoretical concept like comprehensive capacity building, like country ownership, and so on and so forth, into something that speaks to into something that is doable, that is practical, that is understood as something useful for moving programs in countries. So what has been doing, what we have been doing in collaboration with many organizations and different partners, we have proceeded towards a systematic literature review, trying to look for the best evidence. We have indeed evaluated and assessed lessons learned from countries, from many implementers and many country programs, including those that ECPAF supports, and also conducted a survey in 15 sub-Saharan African countries, assessing and trying to understand what the system barriers were, and trying to go in a little bit granular into the assessment of the needs. And here in this slide, you can see on the left side of the slide, you see the health system building blocks, which is very clear. And on the other side, indeed, you see suggest the best practice that we have identified as practical approaches that could be taken forward, that are today implemented in countries. And throughout the discussion that I will be going through, I will try to show some of the data that support these approaches. So here, as I was saying, let's try to go building blocks by building blocks very briefly, trying to share with you the data that we have found that support argumentation that approaches like integration, decentralization of HIV services indeed can be a practicable way to operationalize health system strengthening as long as task shifting and innovative financing or introduction of innovative technology in the centralized setting. So starting with service delivery and integration of HIV services. Our focus is, and our priority is HIV. However, as we are moving toward country ownership once again, we know that the mandate of Ministry of Health is much broader. And we also know that they will and also the resources for continuing to focus on a vertical approach probably will be limited in the long term. Additionally, we also nearing the end of aid exceptionalism, both in terms of funding and in terms of service delivery model. That said, here I'd like to show you some data about integration of HIV services with primary health care. And you see here that when services are integrated and decentralized, the number of people starting ART in 90 days from the HIV testing and starting ART in total increases. In addition, here is another example in 58 WHO countries that shows how we are moving towards integration of HIV and hepatitis C. And again, here, and it's another approach, in addition to integration, we are talking about decentralization. Decentralization is also a critical component of strengthening service deliveries. And here we see how the more we decentralize from central hospital to district hospital to primary care facility, we see how retention rates increases. Another positive impact of decentralization is in addressing equity. Here again, the more we decentralize from hospital to rural center, we see that the number of people on ART increases, but also proportionately the increase in women accessing HIV services goes up. So this is a very important element that should help us in guiding in the implementation of the different approaches. Here we have another very interesting example that comes from community campaigns in Uganda, where we see that the leveraging effect of community-based HIV testing campaign, in addition to detecting new HIV infection, the community and the intervention of decentralizing that specific intervention in the community resulted in detecting new cases of hypertension as well as new cases of diabetes consistently in the different provinces. If we move along human resources for health, we have talked a lot today about nurse initiation. We know, and this is the result of a randomized controlled trial in South Africa, there's really the quality of care provided by doctors and nurses is exactly the same. Here we have the results, and then if we go along, we know that also, this is a randomized controlled trial. They are also recently being published by WHO, a systematic literature review about pediatric HIV care and treatment, seeing how task shifting actually can ensure the same quality of care. So we know that even the WHO guidelines are recommending nurse initiation of antiretroviral therapy. This practice has to be picked up because it's actually one of the big limitations in countries. And then we go into some more bigger issues like governance. Governance goes beyond HIV, but is definitely part of it. And if we take the example of Rwanda, for example, where, as recently reported in the BMJ, the HIV epidemic drove the health system agenda. And here, you can see a quote of the minister saying that if you give Rwanda money to save the life of the oldest person today, we will make sure that the infant born tonight benefit as well. So we increasingly going toward an integration of services and intervention. This approach in Rwanda actually resulted in an important increase in patient on ART, as we can see on the graph on the left side, as well as other indicators. For example, Rwanda has the highest decrease in maternal mortality in all sub-Saharan Africa. And as we talk about capacity building and we talk about country ownership, was one of the first countries receiving direct funding support from PEPFAR. As part of governance, also, it's very important to strengthen civil society. And here I would like to show an experience by ECPAF. As just mentioned previously, as one of the big transitions was the track 1 countries were transitioned to national partner. And in that context, ECPAF supported the scale-up of independent civil society organizations in Tanzania, Cote d'Ivoire, and Mozambique. And our focus in building this civil society organization was really to support a comprehensive capacity building. So after 3 years today, the affiliates, as they are called, are national independent civil society organizations that support more than 650 sites across the 3 countries. They support 180,000 patients on treatment, and they have a budget of 30 million. And equally important, they are now independent leading national voices and advocates for the HIV response in their respective country. If you go into health financing, here is a broad financing issues, and this is some data that are coming from UNAIDS. Here we see that in Asia and in the Pacific, countries are sharing responsibility as GDP rises. And here we can see a correlation between GDP on the y-axis and domestic HIV spending. If you go into another aspect of financing, for example, as result-based financing, this is also a very important innovative financing mechanism that is not so innovative indeed, because it has been implemented since 1990 by the World Bank, and then progressively Global Fund, and now also many of the USG implementers. And here, what is important about this innovative financing mechanism is that it pays on outcomes rather than inputs. And the second very important thing is that it empowers the facility or the health workers as well as the district. The third important thing is also a new way, as also a mechanism for us to understand and maybe reevaluate the way that funding is provided to national entity. Lastly, but not less importantly, is a mechanism to improve performance. And we can see in these slides, again from Rwanda, how in the last 10 years, access to services, and here we have example for maternal and child services, but data are similar for PMTCT and HIV, progressively increases. If you go into the box of commodities, I would like to have 2 examples here. The first one is about the drug prices, and we can see here in this left side of the slide how in the last 10 years, these are the first-line regimens recommended by WHO, and we can observe the massive decrease in price. And on the other side, and this is the slide that these are data that are coming from WIPO, we can see how the decrease in prices correlates with the number of people that can access drugs. And we have, I would also like to cite, I don't have a slide, the example of South Africa, that through a tendering strategy that focus on competition among manufacturers, decreased the price of drug by 53% and saved in 2 years 685 million. Again, and we talked today about this morning about point of care technology and the promising, and we all look to potential of this new technology. Here we have some initial data about introduction of point-of-care CD4, and we can see already, these data are coming from Mozambique, we can see already how we can see already the impact on the HIV treatment cascade. The loss to follow-up between CD4 staging and ART initiation fell from 64 to 33%. The proportion starting ART doubled from 12 to 22%, and the median time to ART start fell by half. And these are initial preliminary data, but we are starting to see, and these data are being confirmed more and more by introduction in other countries. So just to conclude, we know the mechanism for supporting HIV services in low-resource settings are evolving. And we know that there will be these focus on transitioning to national entities will continue and will be further strengthened. For this to work, we need strong health system. This is clear. We need strong health system to advance and expand access to HIV services, to sustain them, to ensure the quality of those services. We need to start thinking in chronic care terms. However, and here I cite Tolstoy, as he was saying in Anna Karenina, happy families are all alike, and every unhappy family is unhappy in his own way. So similarly, country health systems are weak in their own way. One size fits all will never work, and we have plenty of demonstration of evidence that if we want to be if we really want to sustain the HIV response, we need to approach it in a way that is country-tailored. So we need solutions that can solve specific country problems. We need national leadership, high level of political commitment to equity, to service delivery, as well as a clear plan of action. We need country ownership approach. It's about time. Again, evidence-based intervention. We talked today about the right thing. We know what the right things are. We have evidence for that. We can continue to improve that evidence, but at the same time, we just have to make that evidence change things in country. Very important is community system strengthening. Engagement, the engagement of the community is critical, both in increasing demand for the services and also in providing the services themselves. We can see that more and more. We need quality improvement and strategic metrics, as well as cross-sector collaboration between public and private sector. More and more, the private sector is becoming a very important entity to involve in the HIV response at global level and the local level, as well as other line ministries. We don't only need the Ministry of Health. So there are solutions, but it looks like we need to change our mindset. Still today, health system is a black hole for donors, as it is very difficult to see return on investment. It is overwhelming for many countries because it's a very long-term engagement. It is threatening to implementers and program managers because it definitely dilutes the effort of the vertical programs. So we need to change and demystify health system. And we really need a new narrative for health system strengthening and for solving the health system issues. And we need to write that narrative together. So concluding with a citation from Michel, if a virus that is HIV and a bacteria that is B can work so well together, why can't we? Thank you very much.
Clear, or the caffeine hasn't quite hit in yet. Thank you.